Please start.
Start the timer.
Timer, please.
Okay.
Yeah.
Good morning, respected judges and everyone present here. My topic is comparison of retinal imaging using smartphone and indirect ophthalmoscopy in emergency rooms and wards. Ophthalmoscopy is required to be done in various emergency and non-emergency settings. It's a useful clinical tool in emergency room to rule out certain life-threatening conditions like features of raised ICT in the form of papilledema. Retinal and disc imaging has been important part of assessment of other medical emergencies like trauma, hypertensive emergencies, optic neuritis, hemorrhagic disorders, etc. In non-emergency settings, diabetic retinopathy, hypertensive retinopathy, ocular tuberculosis, and various ocular vascular occlusions are the main indicators of ophthalmoscopy. In addition, it also forms an integral part of examination of children under anesthesia in operation theaters for tumors like retinoblastoma. Various methods of ophthalmoscopy are there. Conventionally, it is done with ophthalmoscopes direct or indirect, which are portable but have limitation of ability of image storage. In addition, requirement of a trained examiner cannot be overlooked. Retinal imaging systems are excellent tool for use in ophthalmology clinics. This study was done to compare the utility of smartphone ophthalmoscopy with conventional indirect ophthalmoscopy in emergency rooms and wards. It is a clinical prospective single mask comparative non-interventional study. The study was done in emergency rooms and acute care of tertiary care hospitals. Total 100 cases were taken and pupils were dilated with tropicamide drops and put twice at a gap of 30 minutes. Indirect ophthalmoscopy was done using this using the smartphone and the N20 diopter lens and indirect ophthalmoscopy. The videos were captured and stored in a data bank, and conventional ophthalmoscopy is also done with 20 diopter lens. Comparing the results, we mainly out of 100 patients, normal findings were recorded in 70% patients. 10% had disc edema, 12% had hypertensive retinopathy, and 8% had retinal hemorrhages of various etiologies like diabetic retinopathy, trauma, platelet disorders, etc. The average time taken for smartphone ophthalmoscopy was larger, that is 126 seconds, in rather than in conventional ophthalmoscopy was 102 seconds. The sensitivity and specificity for smartphone were 80 and 86% respectively when compared with indirect ophthalmoscopy. To conclude, in this study, good correlation was found in both the methods. The images were acquired in reasonable time available in the clinic. The quality of images were realistic for analysis. The results showed good correlation between the two methods, which was clinically and statistically significant. This method seems to have immense potential to be used in community settings, that is easily available, low cost and wide applicability. It is portable and potential of data transfer with mobile network. It is now estimated that almost 50% physicians use smartphone. This device has versatile camera and excellent screen resolution. This method has extended utility of being used by technicians in community settings. The ever expanding mobile network and use of data clouds make this procedure more lucrative with regards to teleophthalmology. Similar approach of retinal imaging can be used by medical personnel in remote locations in certain life-threatening conditions like papilledema or high-altitude cerebral edema. The images can also be sent to ophthalmologists for opinion. And the limitations of this study was in required of patients with clear media, which is comparable with both indirect and smartphone ophthalmoscopy. To conclude, this study has clinically and statistically significant correlation was found between smartphone and conventional ophthalmoscopy in retinal assessment of medical emergencies. Thank you.
Nice presentation.
The
Illumination wise, what difficulty you face?
So, pardon?
Illumination wise.
So illumination wise, initially earlier smartphones were little bit we face difficulty, but nowadays smartphones have evolved so much, like even with a gap of 1 or 2 years, 2 years back, the smartphone illumination or the camera quality was subpar, and now it is far better. Now it's more easier, the quality of images are more better actually nowadays, even with a gap of 1 or 2 years, because we have done earlier also. I've been doing since I've done from 1 or 2 years back with old smartphones and now with the new smartphones. so they have better quality of images.
Tell me one thing. Previously, smartphones didn't have this option. Now you have these smartphones. You keep the illumination on and you go into
Yeah.
the video mode.
Yeah, yes, sir. Exactly
right?
like that.
So that
sir.
is how you take it.
Only the problem is just the focusing, sir, because initially, which
But is
like
the illumination from the flash of the
Camera, yes, sir.
laptop, the mobile enough
yes, sir, it's
to
quite
penetrate
enough.
through
yes, sir.
everything?
Yes, sir, it's very clear picture. it
Okay.
comes.
In the study, you said about some time
Yeah,
it took
time
for
taken,
scanning
yes, sir,
or
that's true.
whatever.
It
So
takes-
how did you judge that? Because when you're doing an indirect ophthalmoscopy, you're not really timing yourself.
we did time ourselves.
So
while
what was it? In finding a particular
Yeah.
lesion, or how
Yeah.
did you
Uh,
have the start point and the end
the
point?
start from the start of indirect ophthalmoscopy till the diagnosis of the fundus, either it is normal or with any pathology. It's like that.
So
hereditary
why
modeling.
did smartphone take a little more time?
The practice, sir, because even though we are more accustomed to indirect ophthalmoscopy, so that's the factor, sir. Because if we practice more with smartphones, then it will be shorter, sir, definitely.
Yeah, so you should have rephrased it. Don't make it capture time, because capture is capture when you take a photograph, and
Okay.
that you can't do with indirect.
Yes.
Right?
Yes.
So the time taken for assessment varies.
Okay.
Right? So that is something that in the study you should have emphasized
Achha, yes.
and made positive features about it. But it's a very good study. I think you continue with it and make it a more useful one.
Okay. Yes, sir. Thank you, sir. Thank you, sir.
Can we have our next speaker, Dr. Haripriya Arvind?
Good morning. My paper is titled Comparative Analysis of SC Depot Steroid to Using Topical Steroids and NSAIDs in Phacoemulsification. We all know the trouble with using eye drops, and this could range from issues with compliance to improper application to mix-up of eye drops. This is especially a problem for all patients undergoing phacoemulsification to use their routine topical steroids and NSAIDs following surgery. So some surgeons have injected different doses of depot steroids, either subconjunctival or subtenons, and this is the range they have used, between 4 milligram to about 40 milligram, and this varies based on how far it is injected from the limbus. So we are using the dosage of 4 milligram in 0.3 ml as per Dr. Neil Shorstein's recommendation, and this is given about 6 millimeters from the superior limbus. So this is the preparation of the injection. So we use the unpreserved triamcinolone. We draw in 1 ml, which has about 40 milligram of the drug. This is diluted with 1 ml of distilled water, and from that we draw in about 0.3 ml. So this makes it about 6 milligram. And this is injected in the subconjunctival space using a 30 gauge needle. This way we don't have any reflux. Insert about at least 2 or 3 millimeters, 6 millimeters from the superior limbus. So the purpose was to compare the efficacy and safety of single subconjunctival depot triamcinolone acetonide with topical steroids and NSAIDs after uneventful phacoemulsification. So this was a prospective, multi-centric, amongst the 3 centers of Arvind Eye Care System, randomized control trial. Most of the previous studies were either retrospective or had small numbers, even if they were done as a RCT. So group A included about 200 eyes of 200 patients who received Tricot 6 milligram in the superior limbus, and group B included 202 patients who received topical pred acetate for 6 weeks tapering doses and dipephenac for 3 times a day for about 1 month. All patients in both groups received topical ofloxacin and intracameral moxifloxacin, and the follow-up was 15 days, 45 days, and 90 days post-op. We did not include patients who were very young, less than 40 or over 80 years, known cases of glaucoma, family history of glaucoma, high myopes, any significant ocular comorbidity, or any intraoperative complications like a capsular tear or posterior capsule rupture. Looking at the demographics, both the groups were comparable in terms of age, gender, and the laterality. The best corrected visual acuity was analyzed, and the preoperative visual acuity in both groups was 615, which improved to 6.4.8 in both the 45-day and the 90-day follow-up. And this difference was not significant because the visual outcome was very similar. We looked at the intraocular pressure, and again, they are both comparable in the pre-op as well as in the final follow-up. It reduced by about a millimeter in the final follow-up compared to the pre-op, and there was no issue with glare. We had one patient where we had to remove the depot because of sustained IOP spike. The postoperative inflammation, which required additional medication, were 2 patients in the subconjunctival steroid group and 4 patients in the topical steroid group who required more medications compared to what they were already using. We also looked at macular thickness, and the mean macular thickness was 189, 191 in both groups, again not statistically significant. 1 patient of CME was noted in each of the groups. So in conclusion, a single dose of subconjunctival triamcinolone acetonide injection was found to be safe and effective and non-inferior to topical steroids and NSAIDs following phacoemulsification.
Should I ask? Ma'am, very nice presentation. How long did the subtenon steroid stay before it actually went off? Because you must have followed up beyond the period of their study.
Yeah,
right?
so this was 90 days. So I think most patients, at the last 90-day follow-up, we had the depot in about 30 patients
Out of the
out of the 200.
200.
Yes.
So about 15% had retained.
Yeah, and also that was also not like, I think it was more the vehicle, it was a very less small quantity.
Right.
But the good news we found with this sample, the main thing was the dose was seeming to work. So earlier before this, we have done it in many patients. We compared 4 and 6 milligram.
Right.
4 seemed to be inadequate. Some of them had inflammation rebound. Whereas this dosage, we were concerned if stepping it up would have an IOP spike and glaucoma. We did not see that as a major problem.
Did you rule out any systemic problems in the patient like diabetes or anything?
So diabetes we included, I didn't have it added here, but with any patients less than 5 years of diabetes we included. Over 5 years we did not, because we just did not want to have any patients with CM, because visual acuity was our main outcome variable.
Right. Thank you.
Ma'am, I understand the need of this study, and did you choose those patients where follow-up was doubtful, or just any patient it was in a
No,
sequence?
this
it
was a
chosen?
properly done randomized control trial with all the consent form from pre-op and prospect.
Both free or paying,
I chose all the paying patients.
paying patients.
Yeah, this was kind of our standard of care. We've done it for over 1,000 patients before this. So I was not doing it as a trial. So I knew that this was working, but I think unless an RCT is there, we would not know for ourselves and the rest if this is actually safe, or at least non-inferior to topical. Of course, the compliance is an issue, but at least it should not have worse for the patient. So that is why this study was designed.
Topical antibiotic was used in these cases?
Topical antibiotics was used in both groups.
As usual?
Yes, we did not change the antibiotic part.
Yeah.
And we used the intracameral moxi, which is again our regimen. The group which got the depot did not have any topical steroids or NSAIDs, whereas the control group had both prednisolone and the nepafenac.
So this was subconj, so in comparison to subtenons. So means because effectivity is there, so definitely intraocular penetration might have been there sufficiently. So IOP spike was seen in one case only.
No, IOP spikes we saw, I think only one patient we removed it because we tried one AGM and the patient was also not happy that they had a depot. So we also give them an information that they're going to have this depot just to keep the patient informed. They were not happy to see that depot, and that was not, that caused some irritation to that patient.
Like this color.
Yeah. That's why we go superior, because then the patient does not feel, concerned. Inferiorly, it's more visible, but superiorly, they can't see it.
Thank you, ma'am.
So, ma'am, did you rule out steroid responders prior to injecting?
Yes, so we removed steroid responders. Anyone who was on, any diseases who may need steroids, like any autoimmune disease, all those patients we excluded from the study.
You excluded from it.
Any family history of glaucoma, all of them excluded.
Thank you.
Thank you.
One question, ma'am.
Yeah.
Was there any difference in ocular surface discomfort symptoms?
Yeah, so we also measured that between the two groups, and surprisingly, we did not see any difference, though we expected. So we asked them 4 points in terms of pain, redness, irritation, and all that. The discomfort was surprisingly similar in both the groups.
And did the patient in whom the depot was removed, did the patient respond IOP?
Yes, it is actually a very easy thing. So just subconjunctiva, you just have to nick it and get it out. So it's very straightforward, and the patient was fine, and there was no issue with that.
Asking because excising a subtenon's depot
This is subconjunctival, so it's
subconjunctival.
very easy to remove.
Right.
It's like just conjunctival, you just resect it. It's very easy, and patient also was fine. There was no issue at all. Thank you.
Thank you, ma'am. Can we have the next speaker, Dr. Ramaya Katari? Dr. Ramaya is not there? Okay. Then we will move to next speaker, Dr. Sanat Kumar. Yeah. We have to wait till if they come, then we can present it. What do you say?
I can do that.
We can wait till then before writing anything.
No, I have written in now. Can then change later.
The more the merrier. You should have a chance to speak.
No, come.
So good morning everyone. I'm Dr. Sanat from MAMC. I'm a third year postgraduate resident. My topic is ocular complication in children of nephrotic syndrome on oral steroids. So we all know nephrotic syndrome is the most common kidney disease in pediatric population in which oral steroids are considered the first line treatment. But several studies have shown that lack of awareness causes steroid-induced glaucoma, which is responsible for around 1/4 of secondary glaucoma in children. And the most common complications seen are cataract and glaucoma. So the study that we did was a cross-sectional observational study of 101 children of nephrotic syndrome over a period of 1 year period. And the nephrotic syndrome children aged 5 to 18 years on oral steroids for at least 12 weeks were included. And we excluded the children who were on topical steroids for some reason, or any children with developmental cataract and congenital glaucoma. So our primary outcome was to measure proportion of glaucoma and cataract. The secondary outcome was to measure level of awareness among caregivers as well as the pediatricians regarding ocular side effects. So we included the children. We did some evaluation, and a close-ended structure questionnaire for awareness was administered for both caregivers as well as the pediatricians. So the parameters evaluated were type of nephrotic syndrome, the doses and duration of oral steroids that were used, best corrected visual acuity, CCT corrected intraocular pressure using eye care rebound tonometer, with lens status and fundus and disc status. And with the questionnaire, we assessed the level of awareness among caregivers as well as the pediatricians. So we included 101 children, around 57% being boys and 43% being girls. 88% were steroid sensitive nephrotic syndrome, whereas around 12% were steroid resistant. We found that around 4% of children had posterior subcapsular cataract, although all of them were visually insignificant. The mean steroid use was around 4,000 plus minus 1,300 milligrams, with an average duration of 47 plus minus 21 weeks. It was not significant as compared to the children with clear lens. Whereas 6 children, around 6% showed a high IOP spike, where the duration and dose were statistically significant, as well as we saw glaucomatous cupping in around 5% of children. So this is an image of a posterior subcapsular cataract. This kid had around 2.8 millimeters of PSC with no visual deterioration. Whereas this is another child with around 0.8:1 cupping. This child was also asymptomatic. We assessed the level of awareness among the caregivers using a questionnaire, caregivers as well as the pediatrician. Around 100% of the caregivers were not aware of the ocular side effects of oral steroids, whereas when we assessed pediatricians, around almost all of them were aware of the side effects, although only 62% reported that they are aware that both cataract and glaucoma can occur with oral steroids. Screening guidelines and time frame were unclear, and 16% being unsure of how often a child of nephrotic syndrome should be evaluated. So in conclusion, we saw IOP and glaucomatous cupping was associated with higher doses as well as duration. Caregivers were lacking awareness, and pediatricians were infrequently advising routine evaluation. So these are our recommendation that at the time of diagnosis only, all children should go a routine ophthalmic evaluation. Patients and caregivers should be counseled about the asymptomatic nature of these complications, and pediatricians should routinely get their patients evaluated. Thank you.
Thank you, Sanath. Excellent concept, excellent topic you have chosen. I don't think anybody has dealt with this before. Only thing is that you didn't talk about the age distribution of your patients, because that's very important. So what is the general age of the children who had a nephrotic syndrome?
Sir, usually, actually, a lot of child present within this age range of 5 years, 4 to 6 years, were the major age of onset that we see.
Why I'm telling you is because assessment of glaucoma in a child is difficult, right?
Yes,
The
sir.
only thing that you can do is probably measure the corneal diameters, see the disc, all these things.
Right.
But if you have a child who is old enough to do a field charting, maybe you will not have the normative values,
Right,
but
sir.
you will at least get a trend.
Right, sir.
Did you get the OCTs done, RNFL of these children?
Yes, sir. The children who were cooperative, we did their visual field analysis also, and this OCT also.
So
But
how did you confirm that they have developed glaucoma? Only by the IOP, nothing else.
no, sir, no, sir. With IOP as well as the disc evaluation. In children, if only IOP is high without any disc changes also, then also we were closely monitoring the child. And if there was sustained raised intraocular pressure, we started on anti-glaucoma medication and kept the patients on regular follow-up. In our study, there were cooperative children above the age of around 10 years. They were cooperative for visual field analysis. So we got a baseline visual field. Although we can't comment on the visual field changes, but we were keeping a baseline so that we can follow them up on regular intervals.
So I think it's a very good starting point for you to go further on the study and see the actual onset of glaucoma in these patients who are going to be on steroid treatment for a very long time.
Right.
And you can probably include other autoimmune problems and all that which have steroid used in it regularly.
Right.
Very good.
Thank you, sir.
So
Thank
what was the nature of this study? Was it a prospective study or was it
No,
a cross-sectional
It
study?
was a cross-sectional observational study.
Cross-sectional
Yes, ma'am.
observational study. Okay. So other thing is, what were the exclusion criteria for these?
So first was children who were not cooperative for evaluation, age less than 5 years of age. Second of all, patients who are taking oral topical steroids for VKC or any other thing, we excluded them, and anyone with congenital glaucoma or congenital cataract. These were the major exclusion
So
criteria.
congenital cataract, how would you know in a cross-sectional study? I mean, the
Ma'am,
type of cataract. you
Yes,
mean to say.
because all of them had posterior subcapsular cataract. It's well known that secondary cataract is mostly posterior subcapsular.
Following this study, did the referrals increase?
Yes, sir. Yes, sir. So we were associated with the pediatrics department of MAMC. So as soon as we started, it was a 1 year long study. So it became a routine that all kids were sent to us, whoever presented in the nephrotic clinic. Thank you, sir.
Just when you present, when you say cataract, that time only if you show the photograph, it will bring a flow in your presentation for future, I want to say. Otherwise, it looks incoherent.
Thank you. Thank you so much.
Can I have our next presenter, Dr. Ravindra Kumar Chaudhary? Yeah, please.
Respected dignitaries on the dais and off the dais, a very good morning to all of you. My topic today is perception of faculties on online medical aviation. During COVID-19 pandemic, educational institutions worldwide shifted to online educations. However, these transitions presents challenge for institutions, instructors, students, necessitating rapid adaptation to this new mode of learning. So with this background, the present study was undertaken to discover the perceived advantages and disadvantages among the faculties. This understanding will enable us to leverage the benefit and address the drawback effectively. This is a cross-sectional observational study where a pre-tested semi-structured questionnaires on perception regarding online medical education was sent. Response were 100 questions were attempted, were included in the study. The questionnaires were divided into the 4 sections. Section 1 consists of demographic profile. Section 2 consists of readiness to switch to the online mode, preparatory time required, internet speed, face-to-face interactions, and the section 3rd includes advantages and disadvantages of online teaching as well as online examinations. And 4th sections includes futures perspectives of these online educations. 121 faculty members participated in the studies, and 56.2% said more than 5 years of teaching experience. 39.7% of faculties were ready to switch to this online mode, and 52.5% of the faculties noted that there was adequacy of internet speed during their classes. And only 24.8% of our faculty members have experience of online teaching before COVID-19, and preparatory time is more in 52.7% of our faculty members. Coming to the advantages of online classes, classes can be taken at its own convenient time. Holiday and vacations can be used to complete the course. Minor illness of students will not be a hindrance to the class. These are the major advantages, and the non-availability of high-speed internet, practical classes on online modes are effective. Lack of computer skill among teachers are disadvantages. Coming to the online examinations, it can be conducted during pandemics. Physical presence of external examination is not required. Manpower required to conduct the examination is less are the advantages, whereas students' integrity and difficulty in evaluation of answer sheets and practical examination are difficult to conduct are the disadvantages. And the lack of face-to-face interaction was perceived by 81%, and more discipline and integrity is required in 83.3% of our is required. And 91.5% of our faculty members want to need a workshop for online educations, and 91.7% of our faculty members want to implement this hybrid mode in future. So this is the comparison among senior and junior faculties. The major difference we noted is that most of the junior faculties are ready to switch to this online mode. Comparing with the Rohila et al., they have found no face-to-face interactions and internet issue were the commonly stated barriers, and provision of recording, glued platform for introvert students, social distancing and suitability of time are the major perceived advantages. This is the demographic profile comparison with other studies abroad and India. To conclude, 91% of our faculty are in favor of hybrid mode, but most of them need a workshop or training for a better implementation of online educations in medical college as per our study. And in view of the emergence of new medical college in remote areas nowadays, the online mode can be a solution to overcome these problems of shortage of faculty, as well as beneficial to the students to learn from an experienced teacher from a distance place. However, conducting examination in online mode as far as medical colleges are concerned, where the skill is examined, it should not be considered unless and until social distancing is mandatory. Thank you.
Yeah, I think it's a good study. Could you analyze regarding practical teaching of the students, clinical skills teaching
Yes,
during this time?
actually this idea came to our mind while to conduct a study when we are teaching in the medical college during the COVID era. At that time, we were able to teach the theory part, but to conduct the practical examination, practical part is very difficult, as it is skill is required, and moreover, integrity of the student is required to be concerned. So whether the patient is learning well or not. And further, the examination, conducting examination, mainly the practical is the only drawback of this online mode.
Another thing that was a problem was the availability of internet. At many places, this Wi-Fi was not available, so that would disrupt the teaching, and that would affect the students also. So at some places, the teaching was affected because of the non-availability of a continuous internet.
Yes, sir. Yes, ma'am. This is the major issue. By doing this, the purpose of doing this study is to that mainly these institutions need to provide high-speed internet speed. But during the COVID era, anyhow we have managed the situations. But further for the time as the it is linked to the competency-based medical education nowadays, and that mainly focus on online education. We have to provide online internet speed should be adequate for this
government
purpose.
agencies
Have to be aware, and it should be
And
implemented.
what was your experience in teaching surgical skill sets?
Surgical
Because
sets,
that was a limitation with online teaching and still remains a limitation with online teaching.
yeah, you can.
So did you do a further extension of your study on this aspect, that how was the effect of, how we were going for online, people are ready for online, but is it compromising on their surgical skills and physical training?
No, surgical skills that it will be beneficial in one way is that they can see their recordings or recording of the expert surgeons from the distance place. That is
Right.
one of the advantage online mode of, because
Right.
from in the same institute they can see the direct side, but from the online mode they can see from a distance place. That is one of
Yes,
the
so
important
live
things.
surgery workshops and all that were very useful.
Yes, sir.
But then if you don't do it physically, there was a limitation.
Yeah,
So
that is
a lot of people have
that
got
is
very
what
poor training during this period.
yes, sir.
So you should have emphasized that on your talk.
Yes, sir.
Thank you.
Thank you, sir.
Dr. Subhashini.
Very good morning to the dignitaries present on the stage and my seniors and colleagues. I'll be presenting on thesis to publication, unveiling hurdles in the pursuit of publication from a resident's perspective. Background of the study: research is an integral part of residency, where working under mentors plays an important role in setting the ground for further exploration in the field of research and publication. Why research? A study conducted by Nair and et al. Concluded that perception of residents towards research include enhances critical thinking, it adds to their knowledge of medicine, it acts as a stepping stone to publish scientific papers, and it enables recognitions among peers. Data from our institute reveals that 15.2% of our residents have published their thesis. Aims and objectives of the study include to understand the hurdles in converting thesis to publication and to identify phases of the thesis journey where residents appreciate guidance. A validated questionnaire was administered to ophthalmologists who have completed residency from our institute in the last 4 years, and the results were analyzed. Out of the total responses received, 24% had published, and where are they now? 20% are medical consultants after subspecialty fellowship, 16% are general ophthalmology practitioners, and 44% are pursuing their subspecialty clinical or research fellowship, and 20% were residents who had just finished their exams. What was the motivating factor for thesis publication? For most of the residents, it was a mentor or guide who pushed and motivated them to start the work, and for us, it was interest in research and as a requirement for job opportunity or fellowship. Guidance was required at which stage? For 50%, it was language, and for the rest, it was choosing the right journal, statistical analysis, and writing the right conclusion. Reasons for delay in publication. A whooping 52.2% agreed that it was lack of time, and for the rest, it was lack of motivation, delay in acceptance due to rejection, as they had to edit their manuscript multiple times after that, and miscellaneous reasons like being engaged in other projects or applying for fellowships or just busy being in life. When was the thesis published? 56% who had published had started their work within 6 months of completing their residency, which means whenever earlier work is started, there is always an earlier chance of success as they're already on track. A lot of theses have more than one parameter being studied. So the question was asked, if a single parameter or an objective was considered for refinement and publication, was there an earlier chance of success? And 36.4% agreed so. What will actually help? Periodic review with mentor in the form of Zoom calls or face-to-face meeting whenever possible. Consistent dedicated time for thesis in the form of 2 to 3 hours per week. Being updated with a study coordinator with the thesis timeline. And working with a catalyst co-author. A catalyst co-author is a person who has experience in publication, who has contributed significantly to scientific journals. Adding them as co-author, working them will significantly help the residents. Now that we have seen the major hurdles like lack of time, motivation, and some of the factors which will help, we analyze what were the other research catalysts which will help residents. The first in the list, we have the research methodology workshop, which is organized in every institute, and we'll see the rest. First in the list, we have the write-a-thon. Thesis writing can be a daunting and lonely task for a lot of people. And write-a-thon is an intensive writing workshop which is organized 3 times a year, and it provides a supportive environment to set realistic goals, plan writing schedules, and to stay focused. 3 to 4 months ahead, we get the write-a-thon announcement, and during the preparation time, project decision is done, literature search and manuscript preparation is done. And 1 month ahead, we get reminders, and on the submission day, our mentors are always available with us to answer all our queries. A room with Wi-Fi access and Grammarly access is given. Final editing of manuscript and pictures are done, and the manuscript is submitted. And finally, we wait for acceptance. This is the data from Orange Street over the past few years. Next in the list, we have Wall of Fame. Residents who have published their thesis make it to this prestigious wall, inculcating the spirit within the community. This is the wall, and these are our residents. Next, we have the first publication award, where young researchers are recognized for their contribution, and they are awarded during the annual Hospital Day function. Implications: although thesis work is mandatory in residency, only a few of them make it to journals. Despite doing quality research, work goes unrecognized. Actionable insights derived from this study can go a long way in addressing challenges and converting thesis to publication. Thank you.
Very useful and insightful study. I think
Yes,
it
sir.
will motivate all other
Yes, sir.
residents also to take up publication.
Yes, sir.
During this write-a-thon
Yes,
that you conducted,
yes, sir.
how many hours students were writing?
It's organized for 2 to 3 days, sir. Whenever we have festivals coming up like Diwali or Pongal, the OPD is generally tends towards the lower side. So we utilize this time to productively use this time. So 3 to 4 days we are given time. From morning till night, the halls are kept open and residents are encouraged to participate.
Okay, that's very good. Thank
Yes,
you.
sir. Thank you, sir.
Very nice.
Yes, sir.
Need of the hour.
Yes,
I
sir.
must say, the initial slogan was publish or perish, and now it is converting to publish and flourish.
Yes, sir.
Okay,
Yeah.
so this is very relevant. Just tell me, whenever we think of writing, we feel the work is already done.
Yes, sir.
Okay. So, what should you do to get the idea? Apart from what your mentor says,
Yes, sir.
if it has to be inquisitive from you, what will you do to get the idea? What should be the topic?
Yes, sir. I think it's just seeing others which motivates us is what I actually feel.
Apart from motivation, talk science.
We should be interested in our work. Thesis is something that we do from day one.
Oh, okay, you are
Yes, sir.
interested.
Yes,
but
sir.
topics I'm asking.
Topics. More scientific topics which we feel that will make a significant difference in the community.
You subscribe to e-table of content of
Yes, sir.
all medical journals. That
And
is
see what
free
is
of
actually
cost.
happening. Yes,
That
sir.
you will know what is going on
Yes, sir.
around.
Yes, sir.
E-table of content.
Contents. Yes, sir.
So that will give you fair amount of ideas. Just now it has been published.
Yeah.
So why I should not be there in that list?
Yes, sir. Definitely. Yes, sir. Thank you.
Thank you.
Yeah, next speaker is Dr. Rishi Sharma.
Permission to start, sir. Good morning to you all. I am Colonel Rishi. I am posted at Command Hospital, Lucknow. This is a study of effects of alpha-adrenergic antagonists on the iris parameters, which provides an operative challenges during cataract surgery. Just the introduction, alpha-adrenergic antagonists like tamsulosin, alpha-zocin, terazosin have used for a variety of medical conditions which include BPH, hypertension, dermal necrosis. They have a direct effect on the alpha receptors of the iris. There are ultrastructural changes in the iridal stroma, and it leads to the IFIS. So the main aim of the study was what are the effects of the alpha-adrenergic antagonists on the iris parameters and the subsequent challenges. The materials and methods, the area was the Department of Ophthalmology. We had patients who were generally on treatment with alpha-adrenergic antagonists, primarily the BPH and the hypertensive patients. The sample size was 30 patients on treatment and 30 aged match control studies. The parameters studied were the pupillary diameter, the DMR thickness, and the DMR and SMR ratios. The inclusion criteria, of course, the patients primarily on alpha-adrenergic antagonists, exclusion anyone who had undergone an ocular surgery or on ocular drug therapy for long, and systemic medications, especially diabetes. The study technique, after the ethical committee clearance, the journal and ophthalmic history was taken. And this is the anterior segment OCT, which shows the various measurements done. These are the dilator muscle radii and the smooth muscle radii, along with the scleral spur and the pupillary margin, which is seen. And the results in analysis, majority of patients, in fact 27 out of 30 patients are treated on tamsulosin. The main age was generally similar in the study and the control groups. The pupillary diameter was reduced in the study group. The SMR was similar between the groups, and age and eye color were not significant. Just coming to a brief discussion, the alpha-adrenergic blockers, the alpha-1 and the alpha-2, out of which the tamsulosin and terazosin, prazosin, they are alpha-1 selective. The effect of alpha-adrenergic blockers in the eye is on the blood vessels of the conjunctiva, where the tamsulosin has the greatest affinity to the alpha-1 receptors. So they lead to a reduced number of myofibrils and the increased vacuolation, which have been done in vivo studies using the OCT. And in fact, the tamsulosin remains for residual period in the aqueous humor 7 to 28 days, even after post-stopping of the therapy. Intraoperative floppy iris syndrome, if not anticipated, if the history has not been taken properly, it's a nightmare for a surgeon. And especially when the initial, when you reach in the OT and the first, second, third cases with IFIS, then suddenly you realize the list is long and it's a tough man's journey for the entire day. IFIS triad, it was given by Dr. Chang and his colleagues in 2007, which includes billowing iris, progressive intraoperative meiosis, and the tendency of spontaneous iris prolapse through one of the incisions. Highly prevalent in alpha-1 antagonist tamsulosin. The diagrammatic representation shows just the three features of the triad. Therapeutic strategies, the OVDs, iris hooks, retractor rings, and the soft shell technique. As per the various published studies, stopping the tamsulosin treatment per se does not lead to any improvement. Though it has been said that you stop the tamsulosin therapy about 2 to 3 weeks or even 10 to 14 days, still with that duration, there is not, because as I said, the residual effect of tamsulosin in the aqueous humor generally remains even after 7 to 20 days of stopping the therapy for even 6 months. The only case where the tamsulosin stoppage in combination treatment with dutasteride, which has been used, is the one, if it has been used for 6 months and then stopped, probably the effect is gone. The final summary, the alpha-adrenergic antagonists have the pupillary regulation, and it's a challenging cataract surgery. Clinical implications, the most important, you have to have a communication between the physicians and the treating ophthalmologist, so that the ophthalmologist can tell the problems and the treating physician knows when to stop those drugs or advise accordingly the alternatives. And once you are prepared for this IFIS, then of course you can preoperatively, intraoperatively manage and combat them well and minimize the risk of complications. These are the references. Thank you very much.
Presentation, but
Thank you.
just let me know whether was there any association between the duration of the drug intake and
actually the drug intake, the duration as such was not very clinically correlated, though we did what I was mentioning in the results and analysis as well. The per se the drug duration stoppage had no role,
No,
but
how
of course
long?
with yes ma'am, with the drug duration over a prolonged period of time, of course had changes in this, in the iris parameters and all.
And supposing the patient, no, what I want to know is, supposing the patient is on tamsulosin for say 2 months and
Ma'am.
somebody who is for 2 years, was there a difference? Did you find that out?
Ma'am, I did find it out, although I'm not mentioned in the results and analysis. There was a significant difference between this. Of course, ma'am, the case number, the numbers which are taken were very small.
Yeah,
And
30.
So that was, very difficult to, because there were not too many patients who could actually, there was no documented this thing, they were on 6 months. So though we tried it, but yes, of course, we could not establish it very clearly,
And
the correlation.
any effect of age?
Ma'am, the mean age was generally the same between both the controls and this, so I did not find
could not
any,
find.
yes ma'am.
Okay, thank you.
What did you say? Means where you saw the change, the numbers were very less.
Sir, I mean to say the study sample is too small.
No, the change where you saw there were significant changes.
Sir, there were significant changes.
But you didn't mention it. Why?
Sir, because the correlation one we could not, with the p-value, did not come out that significant problem.
But that you have to write. That becomes a important finding. Means that you have self-inflicted bias.
So,
And what were the parameters that you were measuring to see the effect of these drugs on the pupil?
sir, one was of course the pupillary diameter, then was a smooth muscle ratio, the anterior segment one, and the dilator muscle ratio between the two. So which showed the significant reduction and the
And did you use a standard protocol to dilate all the patients? Was there a difference in the number of times you were putting? Was that monitored, or
Yes,
the
sir,
type
that-
of drug which is used? Did you use any homatropin 2-3 days prior
no,
to
sir.
the
I
surgery?
did not use. We standard protocol was used for dilating all the patients and
Right, right. So you had a protocol for
Yes,
that.
sir.
Right. So that should probably have been mentioned.
Right, sir.
Right. Anything else?
Thank you.
Thank you, sir.
Thank you.
Next we have Dr. Aditya Anand.
Good morning, respected judges and my fellow colleagues. Today I'm going to talk about Write-a-thon in ophthalmology, which is a catalyst for residents' drives for academic development. So, what is Write-a-thon? It resembles a marathon where you unleash your inner writer to your way of to greatness in forms of publication. Publications are important as it establishes the credibility and contributes to the scientific community. This is an inspirational idea from an Indian Institute of Technology. Write-a-thon provides participants with opportunities to refine their research work and showcase their findings through publication, and it's a structured platform to submit articles and papers for publication during the event. So an academic extravaganza in the form of Write-a-thon is organized twice every year since 2018. This event is held at our institute during the holidays to drive the residents for achieving maximum outcome in the form of publications and other research activities. So this event is divided into pre-write-a-thon, write-a-thon, and post-write-a-thon. So in pre-write-a-thon, all the basic facilities to the residents such as wireless fidelity, Wi-Fi, EMR system, managed by IT and AV team, housekeeping staff, librarian, all things are provided, and rules of write-a-thon are explained to the residents in or fellows, such as a time limit of 48 hours, file size, everything they have explained, and even they are provided with their personal room within the hospital premises for rest and sleep during the night time. Participants and during the event, participant forms teams, a team of 4 or 5 members. Here identify a mentor to guide them. Teams then select a topic of interest. Participants compile a list of suitable journals according to their impact factor, and this allows for a streamlined submission process, enabling them to submit their work to alternate journals in case of rejection, and with the full support of our librarian. So basically, Write-a-thon, it reduces the continuous digital work stress. Participants are encouraged to play fun games of their choices, and they are provided with the Grammarly software for data improvement work. And at last, all the manuscripts are prepared and submitted during the Write-a-thon and is scrutinized by our medical officers. Post-Write-a-thon, all the data are collected, and at the end of the event, all participants are requested to disclose their submissions in which journal they want to send their work. Even those doctors who couldn't submit their work at the end of the Write-a-thon event, they're given an extra week time to properly frame their work along with the hospital duties. So as a result of this academic drive, the publication in our institution has zoomed up in the past few years. More than 300 articles have been published in reputed index journal. This includes the COVID time also. Works ranging from free papers, analytical studies, case reports, literature review, short videos, innovations, and other sections in different journals. As you can see from the data from the year 2018 to 2022, there is our prizes and our publications have spiked up. This is the data of the papers which got selected in the state conferences as well as international conferences, which are continuously increasing. Even you can see here the doctor's participation, the articles submitted, and post-Write-a-thon submission all are spiking up. Last year data is yet to be compiled, but 2018 November, 2022 October. And these are the prizes we have won in various conferences as well as in ACRS, TNO, and AIOC. And the publications in Indian journals and international journals are also spiking up. Approximately 6 months following the event, up to 30% of the submitted work is accepted and published, while the remaining submissions are revised and resubmitted. And it has been a highly encouraging platform with approximately 50% of the first-time participants successfully publishing their article. This demonstrates the program's effectiveness in fostering a culture of research and publication. And to conclude, this academic feast have led to research drive in our residents or fellows and improve the quality of ophthalmic education. This event has also given the participant enormous exposure to all journals, and now other hospitals under Arvind Eye Care System have also started conducting this academic carnival. And this is a replicable model that can be adapted to local needs. Thanks.
Well presented.
Thanks.
I think this is, as Dr. Subhashini had presented previously, it's a good initiative.
Yes, sir.
Basically,
Yes,
the write-a-thon
Yes.
event is conducted after they have completed their study, is it?
No, sir. During our academic residency only. This event is conducted twice, or last year it was thrice a year it was conducted.
Okay, so like in one event they will write part of the study, and later once they complete the study.
It depends, sir. If possible, they can complete during the same event also, during the holiday time when the residents are free, during a long holiday.
Basically, your recruitment and study analysis, all these things have
Yeah,
to be completed.
Yes, sir. But this obviously it takes time. Sometimes it's not possible during the event, so they have given extra time. We give extra time to them after
Sir
for
is
1 week or
asking,
2
is
weeks.
the study already complete when the person is writing the thesis or the presentation?
Sir,
or is it
yeah.
an ongoing thing? That is what he's
No,
asking, because that
it
has its own set of
Yes,
problems.
yes, sir. It can be an ongoing thing also. It can be a thesis also, which has to be published. So there's data along with their guides and they're compiled there, and it can be the recent starting of the any topic also. Like it has to be decided. But the things which are already like for thesis and the something which are already ongoing before, so that can be completed within a given time during the write-a-thon with the help of other mentors and our medical team and our senior doctors who help us. But the studies which are the idea which has come up during that event, that takes time. So that we give them
So
extra
do you
time.
do it only on the third year students, or do it from the first to
First
third?
year itself, sir.
So those who are writing protocol, they are also part of it, and those who are writing their thesis, they are also part of it, or
Yeah.
they have already written their thesis. For that
The
matter.
thesis, most of the final year residents who have already written their thesis, they can easily during the event they can
And
utilize.
obviously, who's writing a protocol cannot
Yeah.
write a paper right now. At
Yeah,
this
but
stage,
they have
right?
been given some extra other topics like for example, any kind of informative topic in some journals or something
Okay.
like, not necessarily thesis only.
So who are the mentors? Who are the ones who are guiding you?
Our senior doctors who have been allotted who already have lot of publications to their credit, so they guide us very properly, like to what to choose, what journal to go up with, and how to publish any article. So everything is guided
So
by
this
them.
is only limited to your institute or other institutes?
The
can also join
other
it?
system, other Arvind Eye Care System is also coming up with this, but first it has started in our institution also.
Thank you.
Thank you, sir. Thank you. Thank you.
I would like to call Dr. Pratiksha. Dr. Pratiksha is here. If Dr. Pratiksha is not there, Dr. Shruti Hegde.
May I start, sir?
Yes,
May I start? Yes. Very good morning. Should I say good afternoon? Yeah. To one and all, and to the respected judges, I'm Dr. Shruti from Manipal Tata Medical College. So my study is on a medical education topic, which we very rarely discuss in the conferences, and I was very happy to see that there were few more medical education topics today. So it's about comparison of feedback and guiding questions to facilitate reflective writing among undergraduates in ophthalmology. So first let us understand what was the need for the study. So all of you must be aware now that NMC has introduced CBME, competency-based medical education, which has made it compulsory to teach and assess affective domain-related competencies. So what is this affective domain? This is considered the most challenging domain both to teach as well as to assess. So this is a domain which is concerned with emotions, with communication, with feelings, mainly the soft skills, which are usually left to the students to be, to be caught by themselves. Reflective writing is proven as an effective tool to both teach and assess soft skills for undergraduates as well as postgraduates. Our study explored two different methods of teaching reflective writing to the undergraduates. So the purpose was to evaluate and compare between the efficacy and usefulness of guiding questions and feedback in facilitation of reflective writing. It was a semi-qualitative study wherein we took 30 students. So before that, let me just tell you all what is reflective writing. A practice which involves critically analyzing an experience, recording how it has impacted you and what you plan to do with your new knowledge. So this is a basic model for reflective writing which consists of 6 steps. So where the student analyzes what happened, what were they thinking and feeling at that time after that experience, what was good and bad, what else can you make out of that situation, what else could have been done, and if the same situation comes again, how will it be handled. So 30 students, as I said, volunteers during their ophthalmology clinical postings were made to write 5 reflectives during the first part of the study, that's the first 10 days. After that, they were randomly divided into 2 groups, and one group was given a guiding question, the other group was given a feedback by an expert. And they were again made to write 5 reflectives. So the fifth reflective before and after intervention was compared using a standardized rubric. This is available. This was taken from an already used study. So these are the results. Let me just give you the gist of this complicated table. Both you can see that the p-value is significant. The pre and post intervention reflections. So both the methods are showing significant improvement. But there was not much difference when we compared these 2 methods. Moving on, the usefulness was calculated by the feedback taken by the students, and the feedback said that oral feedback given by the faculty was more useful than the guiding questions. They felt that the guiding questions were helping to standardize but to sequence, but they were not motivating enough. So I conclude that both feedback and guiding questions are efficacious in improving the quality of reflections, but students felt the feedback from faculty was more useful as compared to the guiding questions. Looking ahead, whatever the working place may be, an undergraduate, postgraduate, fellowship, we all are teachers at some point of time. And considering the increase in violence against doctors, number of litigations, so teaching soft skills is a need of the day. And we all need to inculcate the habit of reflective writing among our students, and giving them a proper feedback can be useful to achieve the intended outcome. These are my references, and thank you.
Can you tell us what were the feedbacks that you were, you said pre-feedback and post-feedback, isn't it? So what were the things that you would tell your students regarding reflective writing, which would encourage them to?
So basically, before starting the study, they had one session on reflective writing. What is reflective writing? What are the different ways to do it? And then after they started, when we intervened, the guiding.
So what was the intervention?
The intervention was, one group had a guiding question, 7 guiding questions, which will guide them to, they themselves have to follow the guiding questions, see their reflections, and improve on the quality of reflections. Okay. The other group had an intervention in the form, the faculty gave feedback. Faculty who are trained in medical education gave them feedback after reading their reflections, what is it lacking, what needs to be improvised. So, and these 2 were compared. Students felt the faculty feedback was more useful.
Basically self-reflection, the other one was analysis by the mentor.
You can say that, sir, in simple words.
Right?
Yes,
So the mentoring was found to be better.
Yes, sir, the faculty intervention was found to be, they liked it. Although both the methods helped them write better reflections,
right.
But there was not difference. But the students felt, the feedback that taken by students, they felt that this was more useful. Thank you.
Thank you. Thank you, ma'am.
Dr. Vedant Rajoria is there?
Well within the time.
If not, I think we'd like to go back to the previous speakers who were not there. Dr. Atul Birud.
Permission to start, where you engaged with some other presentation?
Yes, sir. Sorry for that, sir.
Okay.
May I have the permission to start, sir?
Yes, please go ahead.
Finish it fast.
Good afternoon, one in all. I am Dr. Atul. My topic is Trash to Technological Triumph, Indigo, a universal slit lamp mounted indentation gonioscopy photography. In 1990s, Alexio Trantas, a Greek ophthalmologist, described anterior chamber angle using direct gonioscope with simultaneous digital indentation at limbus. Later on, Maximilian Salzmann used contact lens and indirect gonioscopy for with the naked eye is not possible because light from the iris and cornea strikes the ear-tear interface at the shallow angle and it's totally internally reflected. Indirect gonioscopy lens has mirrors to overcome this total internal reflection and redirect the light perpendicular to the lens-air interface. The examination performed at slit lamp. There are few devices which has been developed or are in developing stage. First is ICAM from Clarity Medical System USA. They design wide field pediatric fundus imaging, which can also be used as angle photography if you use 130-degree wide field lens. Second one is team of ophthalmologists from Singapore working on Gonio Pane, which is handheld angle photography device. Third is NGS1, developed by Nidec Japan and released in 2018, which is tabletop contact beams angle photography device. The problem faced by most of these devices are either they have patient has to be lie down or goniogel application. Busy IOPD curtails down the use of such devices. They are costlier devices and there is no indentation advantage. Solution to this is our Indigo, universal slit lamp mounted indentation gonioscopy photography. Material used were 4 or 6 mirror ION indentation gonioscope with handle. You can use Zeiss indentation gonioscope also. Then discarded surgical marker pen, micropore, mobile adapter and any smartphone. So this is ION Vision direct view 4 mirror gonioscope with handle. Then this is used Viscot surgical skin marker 1437, which comes with the paper scale. 23 mm rear portion of the marker pen is cut and removed. And then handle of the gonioscope inserted to the cut end and fixed with the micropore tape for extra stability. So mobile adapter in the eyepiece end while gonio pen assembly at the hinge joint. The height of the gonioscope lens adjusted so that the illumination slit should fall at its center. This is live indentation gonioscopy on the pre-anesthetized eye. So inherent advantages of Indigo, that is slit lamp mounted indentation gonioscopy photography are, there is no requirement of coupling fluid, it's extremely easy to use and patient friendly, it's a hands-free technique. Advantages of indentation gonioscopy also and can be mounted on any slit lamp. So these are few of my patients like plateau iris processes, neovascularization of angle, then angle recession, pseudo-exfoliation of angle, iris melanoma, etc. Take-home message. Indigo, a frugal innovation of universal slit lamp mounted indentation gonioscopy. It's a feasible and easy to install. It can record and capture high definition images of the angle, digital image analysis by teleophthalmology and can share across the world. It shows immense promise in enhancing the diagnosis and treatment of ocular condition, particularly in the developing countries. I don't have any financial interest. Thank you so much.
Thank you.
Thank you.
The device, is it attached to some part of the slit lamp or how do you fix it to the slit lamp?
No, basically we have taken the surgical skin marker, sir, and then the rear portion of the surgical with adjustment, rear portion of the surgical skin marker, which is 23 mm, we cut it, and then we slightly preheat it so that it will become slightly malleable, and the lower portion of the handle of gonioscope, which we use, we just inserted it, and for extra stability, we just wrap it with the surgical micropore, sir. And this device we have fixed on the at the hinge joint of the slit lamp. If you look at any slit lamp carefully, the hinge joint diameter, it is almost same for the most of the slit lamp. So we used and we have tried at the killer microscope, then Appasomi microscope and others also. So it was working quite well, sir, and the height has been already adjusted. If there is some, if the diameter is slightly less, you can cut slightly less portion. So that height should adjust and the slit should fall exactly at the middle of the gonio lens, sir.
So once you attach the gonio handle to the that marker pen,
Yes, sir.
You cannot remove it afterwards.
It is a surgical marker, so it doesn't snugly fit exactly. That's why we are using the surgical micro portion just to have extra stability.
Did you try taking a 3D image of your place where you're putting the lens and making a 3D printer, using it to make something like that? Because that would
no,
be
sir.
more practical, using a pen or something and tying it with a sellotape is not a very stable joint.
Sir.
Right, so did you try finding out if somebody can make you a kind of a holder for your lens?
Yeah, sir, we are
With
on
the
it.
3D printer, you can do it nowadays very well, very easily.
Yes, sir. We'll definitely think over it, sir. But till now, sir, we are quite comfortable, and number of patients which we are actually taking gonio photographs has been increased, sir. Because being so easy to take photographs, earlier we were so lazy that we did not take. We used to skip in busy day-to-day OPD. If it just
And patient is quite cooperative while doing it.
Patient is cooperative. It's like AT, sir, applanation tonometry. We just anesthetize with the proparacaine eye drop, 1 drop, and then you can just get your gonioscopy photograph done, sir.
How is it different from the one available that is with MI RedCam? DGIS is there, no?
Sir, this NGS one and all, they have NGS one of NIDEC. This is a tabletop based contact this thing, sir, gonioscopy, and it required this thing, sir. You have to put gel and all, sir. And
no, MI RedCam I am
pardon,
talking about. That slit lamp mounted, that gonioscopy imaging system is there, no? With MI RedCam, digital gonio imaging system they have devised. So how is it different from that?
That iCam you're talking about, sir?
No.
Medical place. I don't know, sir. Not aware.
So any other such kind of innovation is there?
No, not now, sir.
How stable is that attachment? What you have? How stable is that attachment? If patient moves suddenly, then how stable is that your vertical?
It is quite stable, sir, with the surgical microphone, because that is quite lighter, sir. That gonioscope is quite lighter, and it's quite stable and easy to take, sir.
Is there a learning curve for the ophthalmologist and for the patient also? How the patient should sit and how long?
How the patient?
Is there a learning curve for the doctors? How long does it take to really master the art of your innovation?
Ma'am, I taught my this thing, ma'am, OPD assistant, ma'am. He is also able to take photographs, sir.
He's able to.
Yes.
Stable, good, focused photographs.
Focus photographs, ma'am. Right. Thank you, sir.
Should we go for the next one, Doctor? Dr. Ramya is there? Dr. Pratiksha or Dr. Vedant?